Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for the second season of conversations aiming to bridge gaps surrounding dysphagia intervention. Swallow the Gap podcast is a production of Gap Education, and we are predicated on a mission to improve dysphagia care. Nothing we say is legal advice, nothing should be taken without scrutiny. While we strive for accuracy, we do not imply perfection. We value diversity in backgrounds and opinions, therefore our guests will not always reflect what we believe. In fact, we may change our minds as we learn more because this is how progress is made. Through critical reasoning with open minds, we serve as catalysts for advancement in medically focused speech-language pathology. This episode is brought to you by Phagenesis. For stroke survivors with severe neurogenic dysphagia, the Bendix neurostimulation system provides implant-free treatment through pharyngeal electrical stimulation. Learn more at phagenesis.com. Welcome back, everybody. Today I have Dr. Bendix Labeit. He's a neurology physician at the University Hospital in Düsseldorf, Germany. His specialty is neurogenic dysphagia, among so many other things. It seems like this is the first time on the podcast that we've interviewed a physician, and I think one thing that's incredibly important about this is that we're looking across disciplines, not just stagnating within speech pathology, but really broadening our minds to look for things that can help us to think outside of the box from what we're used to. And so I would like to introduce Dr. Bendix Labeit, and I gave a brief intro, but I would love to hear a little bit more about what you would like others to know about you.
Yeah, thank Tim for the kind introduction, and thanks especially for the invitation. I'm really glad to be able to be here and speak in your podcast and also in your conference. Yeah, as you've mentioned, I'm a neurology physician and I work here in Düsseldorf, and my main focus is neurogenic dysphagia, as well as in my clinical work, but also with regards to research. And I'm very happy to speak about my work and about your conference.
Excellent. And so for a little bit of background, the conference he's talking about is the Rocky Mountain University Hard to Swallow Catalyst for Change in Dysphagia Management Conference. This will be the 6th year going into it. I host it, but the university puts it on, I direct it, but it's through the university. And so Dr. Labeit has been so kind as to speak at this. We're looking at innovative, kind of unique, different treatment mechanisms, trying to explore areas that we haven't explored so much as a profession, kind of not veering from the traditional effortful swallows and pharyngeal strengthening exercises because they aren't good, but looking into new things that can help to push us forward. Because sometimes the new, unique ideas, the things that we don't consider, are sometimes the things that work out really well. They cause the breakthroughs in science, and that's what we're looking at. So that's that conference. So question for you, you're a neurology physician. How did you become interested in dysphagia?
Yeah, that's a very good question. I mean, not most of the neurology physicians get into dysphagia. For me, it started as a medical student, actually. I was working at the University Hospital in Münster, and there was a group among Rainer Jivers who was already very focused on dysphagia. He's one of the leading FEES experts in Germany and a pioneer in FEES in Germany. And basically he asked me, do you want to join us? And I looked at what they were doing and really wanted to join them. And that's how I got into this topic. And then I really loved it from the beginning on. So I dug in deeper and stayed in this area. And I have never regretted it one day. I really love being in this very interdisciplinary area of research and clinic.
Very cool. Sounds like you enjoy what you're doing. No regrets. That's fantastic. So you mentioned interdisciplinary. This is kind of a tangential question. What do you think are some of the benefits of looking at dysphagia as an interdisciplinary science? Because traditionally, we look at the research, it comes from speech pathologists. It comes from people who have PhDs and may or may not be in the clinic. Many of them are, but it's maybe not as broad as it could be. So I'd love to hear what you think are some of the benefits of this interdisciplinary science.
Yeah, I think if you work in dysphagia, you have to work interdisciplinary because it's just an interdisciplinary topic. There are so many different professions and specialties involved. There's no way getting around cooperation. If you really want to tackle dysphagia as a whole, you have to work together with lots of different people. And I think this also gives us a lot of advantages because we all have broadly different angles. For example, I as a neurologist, I always look at the classical neurological treatments and look, do they change, do they influence dysphagia? How can we apply dysphagia as a therapeutic target of the classical neurological treatments that we have available? Medications, but also deep brain stimulation, stuff like this. Whereas, for example, speech language pathologists often have a different angle, also a very important angle. And of course, they spend much more time with the patients and get much more deep insights with regards to diagnostics and have much more impressions just because they also spend more time with the patient. So I really think we have to get it together at the end and work together, because that's the only way you can be successful in this area. Yeah.
Very cool. No, that makes a lot of sense. You mentioned a couple of things that people may be unfamiliar with here. I certainly am very minimally familiar with what you've mentioned as far as like medication-based therapy. And oh boy, I'm going to mess this up. The central compensatory mechanisms. Is that the verbiage you used?
I don't know if I used it so far, but it is a very important topic to me. Central compensatory mechanisms. I mean, we all know swallowing is much more than just a brainstem reflex, but we have a widely distributed cortical and subcortical network also involved in the central control of swallowing. And this is a particular interest of mine, to look for, does this central compensatory mechanisms, do they, so if you have dysphagia, how does the brain react? How does it compensate for dysphagia? And I think there's a lot of interesting research going on in this area. And this is stuff that I think we have to focus on and use to develop stimulation therapies in the area of dysphagia.
So I may be way off, but whenever you say this, I'm thinking about top down versus bottom up learning. So for, of course, like the effortful swallow, we might say, okay, swallow hard, like there's something stuck in your throat, really squeeze the muscles, feel the base of your tongue contact the posterior pharyngeal wall. I wouldn't use that verbiage, of course, but things like that versus this, it almost sounds like you're trying to see maybe how the patients work it out on their own and harness that, or am I way off? It might be, that's fine.
No, basically, I think everything we do and every learning approach, every behavioral approach probably also changes something in the central nervous system. And I think we have to get better at understanding, how is the central network disrupted due to neurological diseases? How is the swallowing network disrupted? And how can we influence it? And this applies probably to lots of different therapy approaches, to the behavioral therapy approaches, but of course also to medication approaches and to the classic neurostimulation therapies that are to date available in rehabilitation research, such as TDCS or TMS, in which we use electric currents or magnetic fields to influence the accessibility of the cortex and to really modulate central networks. But also, for example, with regards to deep brain stimulation in Parkinson's disease, these are techniques that are already available in clinical practice, but we do not know much about how they actually influence the swallowing network and how they influence dysphagia. And of course, also not how we can use them to improve dysphagia. And this is something I'm interested in. Yeah.
Yeah. No, it's extremely fascinating. I just love to hear you talk a little more about the theoretical science behind it, which you've dabbled into that some, but specifically brain stimulation. Can you tell us a little bit about what that is and maybe how it differs from other types of therapy? The one thing that when I heard about this, I thought about NMES, neuromuscular stimulation, which is obviously not the same. How does it differ from that? And what promise do you see with this type of therapy?
Yeah. So how does it differ? Well, with neuromuscular electrical stimulation, you focus on the peripheral system, basically on the swallowing muscles or the peripheral sensory nerves, and you stimulate in the peripheral system. Whereas with the central stimulation, you really try to stimulate the brain. And there are different approaches. So one approach is, as I've already mentioned, the TDCS or TMS approach, in which you use an electric current and you apply electrodes directly to the skull and stimulate the cortex of the brain and influence accessibility. And these are techniques that are widely used in rehabilitation, mainly in research to date. So there's not so much done in clinical practice. So it hasn't really translated widely into the clinical practice, but it's used widely in research and does not limit to dysphagia. But we also have dysphagia-specific therapeutical approaches that influence the central network, or are hypothesized to influence the central network, such as, for instance, pharyngeal electrical stimulation. It also targets in the peripheral system. It's an electric current that is applied to the mucosa of the pharynx. And there it applies basically a sensory stimulus, but it is also believed to modulate the central system. And I think if we want to investigate the pathophysiology of all of these techniques, we really need neuroimaging studies to better understand how do they impact the central nervous system, how do they impact the swallowing network during swallowing. Yeah.
Sure. I mean, the theoretical science sounds very interesting. What have you found so far as the data to back this up or not? Has it been promising? Or what has been promising about it?
Actually, the data has been promising. We have a meta-analysis, so studies that look at all the other published studies in the area so far that all show promising results with regards to improving dysphagia in instrumental assessment. So we do have promising study results. However, most of the techniques did not really translate into clinical practice. This is beginning to change with pharyngeal electrical stimulation, because here we now have very specific stimulation protocols that are in use in some areas. With regards to TMS and TDCS, we still have a variety of different stimulation protocols. So we don't really know yet which side of the brain do we have to swallow, do we have to stimulate in order to improve swallowing? With what frequencies do we have to do it? How do we combine it with the traditional dysphagia therapies? Some of them are used in conjunction to behavioral approaches. Others are not used in conjunction, but are used on their own. So there is still much more to figure out. But we have a promising study so far. So I really think it's worth investigating and getting into the topic.
Yeah, no, I think it's definitely worth investigating. I mean, sometimes, not that this is I don't think it's a crazy idea, but this, just for analogy, sometimes what seem to be the craziest ideas are the ones that people won't pursue. And because they don't pursue it, you never know. So you talked about some promising results within this. What about the results have been promising as far as how it's translated to patient outcomes?
Well, I think one very promising approach is or one very important aspect for me is, in general, that it offers us to treat new patient collectives, especially, for example, very severely affected patients on an intensive care unit that are not able to cooperate, that can't be transported to special facilities. So you really need a therapeutical approach, which you can apply directly at the patient bedside in patients who can't really cooperate. And this is something where we really have an advantage, for example, compared to behavioral therapies, because everyone knows if you want to do a behavioral therapy, you have to have a patient who is awake, who is cooperative, who has specific cognitive skills. And I think this is very, very promising here. And we have good study results here. New studies that really showed advantages. And most of them were studies that really used instrumental assessments and showed that these techniques were able to really improve dysphagia, reduce aspiration. However, we do not have good studies to date that really look at other clinical relevant endpoints, such as pneumonia rate, malnutrition, or even mortality, cost of hospitalization, stuff like this. We definitely need more studies here because most of the studies done today have shown an improvement with regards to dysphagia, with regards to dysphagia severity, aspiration, but not with regards to the other very clinical relevant endpoints. And probably this is also a reason why it didn't really translate into clinical practice widely to date. So I think we need more research here.
You know, I appreciate you talking about some of the big picture items, nutrition, hydration, pneumonia, those types of things, because I always want to step back and say, like, well, why is it that we care about dysphagia? It's not just aspiration for aspiration's sake. People can aspirate and be fine. They can be functional and not impact their quality of life. Of course, in other people, they get recurrent pneumonia. They're back in the hospital. It's, significant medical cost. It can affect their health chronically. But there are so many different things that contribute to those big picture health outcomes. Like if you consider it like a pie chart, for example, and maybe 30% of it is dysphagia and 30% of it's something else, and I'm just totally these numbers. But all of these things, say if the outcome is pneumonia, oral hygiene, immune system, dysphagia, like these things work together, and they're going to work together different for each individual patient because each individual patient is unique. So measuring those big picture outcomes is difficult because even if you make a change in the dysphagia, what other things aren't changing because this is a subcomponent of a larger component. And so I can imagine it's much harder to get those big picture outcomes. But with this for dysphagia in particular, it sounds like that's obviously is a necessary step. And if you can measure appreciable, palpable changes within the swallowing mechanism, that's such a huge step in the right direction. So you mentioned reducing the incidence of aspiration. Is that right? Can you tell me a little bit more about that?
Yes, exactly. So just to give one example, it's a study that I know well, is the so-called fast track study. It was a randomized controlled trial published in Lancet Neurology, and it investigated pharyngeal electrical stimulation. And it was done in severely affected stroke patients, and it really increased decannulation, so tracheal cannula, and it really increased the rate of decannulation due to improving dysphagia. And I think this is a huge success because if you have a tracheal cannula, you mostly produce higher costs. You have a much decreased quality of life. That you have to be transported to specific facilities. You can't just go in any facility. Sometimes you even have to stay in hospitals and specific nursing facilities. So this is a huge success. And this is, of course, also because aspiration decreased. Because if you have aspiration and impaired secretion management, this is a major risk factor for not getting a tracheal cannula removed. And this is just an example beyond normal aspiration pneumonia. So it's not only about looking at aspiration pneumonia, but much more other consequences are also related to aspiration. And as you've mentioned, I think it's very important to differentiate between different patient collectives. So in acute stroke patients, I think aspiration is very important. It's a very critical symptom that leads to complications. Whereas in chronic dysphagia patients, we often see patients who aspirate and who do not get aspiration pneumonia. So it really differentiates between different patient collectives and maybe even between different individuals. You're absolutely right in that area. We can't just look at aspiration and deal with it the same in every patient. So we really have to differentiate here.
Yeah. Very interesting. So you had also mentioned something about pharmacological therapy, kind of, switching gears here a little bit. What can you tell us about that?
Yeah. Okay. So I would say there are different aspects with regard to pharmacotherapy. So the one thing is with regard to neurology, we have a lot of neurological symptoms that we can treat with medications. So for example, in Parkinson's disease, we have tremor, rigidity, bradykinesia. We can treat that with dopaminergic therapies. And these classical symptoms, they also contribute to dysphagia because, of course, they don't only manifest during gait or in the extremities, but also in the oropharynx and contribute to the development of dysphagia. And of course, these medications also improve dysphagia. The same is with regard to neuromuscular disorders. In myasthenia gravis, for example, we use symptomatic therapies because we have a lack of acetylcholine esterase. So we can use inhibition medications such as tensilone, mestinone. And of course, they don't only improve muscle functions in the extremities, but also in the oropharynx, and therefore improve dysphagia. So this is the one aspect, just applying the standard medications we use in neurology as a target also, or applying dysphagia as a target for the use of these standard medications. This is the one aspect. And then we have also dysphagia-specific pharmacological approaches that are under investigations. So, for example, C is such an approach. It's basically a pharmacological sensory stimulus used in the oropharynx that also improves swallowing and is hypothesized to modulate the sensory perception during swallowing. And there are also some promising studies here. However, we do not have good results on this yet in meta-analysis. So it really is a rather research topic in this area and not widely used in clinical practice. But I think also these are very interesting approaches and should be further investigated. Yeah.
Yeah. What's neat about, to me, what's neat about this, what I'm taking away is, so in swallowing therapy, there's been this huge push for exercises or compensatory mechanisms that are specific to swallowing pathophysiology. So looking at what's resulting in the inefficiency, what's causing the aspiration. So is it reduced laryngeal closure? Is it the timing, the latency between the bolus entering the pharynx and laryngeal closure? Is it base of tongue retraction? That sort of thing. And so when we use exercises that target the specific physiological process, it's more skilled, right? It's not like a physical therapist seeing somebody who had a stroke and he just puts everyone on the treadmill. Here, hold on to this, get on the treadmill. Like that's one way. But you wouldn't put everybody on the treadmill. Someone has a broken arm, that's not going to help. So why would we do that? And so for the swallow in particular, working on specific pathophysiology. So this kind of takes it back a step further. You're considering the underlying etiology, the mechanism that is causing the pathophysiology from a biochemical, potentially, standpoint. You're talking about dopamine agonist with bradykinesia and reduced range of motion and whatnot in Parkinson's. And so people take these medications, carbidopa, levodopa, Mirapex, a number of different things to help improve movement, gross motor movement of the body. And so what you're saying is this also potentially, not just in Parkinson's, but in different areas, has ways to generalize to the swallow based upon more of a biochemical, physiological level.
Yeah, exactly. And basically, I think this applies to most neurological diseases. Also, with regards to neuroinflammatory diseases, if we have someone with a myositis, for example, a patient with myositis, we use immunomodulatory medications to really reduce inflammation in the muscles. And of course, if we have someone with severe dysphagia is sometimes the leading or even the only symptoms in myositis. Of course, we should also use these immunomodulatory medications to reduce inflammation in the swallowing muscles. And if we do this, we really have to assess swallowing and look, does it improve or does it not improve? Do we have to increase dosage? Do we have to further escalate the immunomodulatory therapy approach? Or can we de-escalate it if the patient is very stable? We really have to get better at applying dysphagia as a therapeutic target of the classical medication approaches that are in use today, that are already available today, but also with regards to in research investigating these dysphagia-specific approaches that really try to tackle swallowing pathologies.
Yeah. Oh, that's cool. It's so neat to see somebody who's a physician interested in this. I have one of my very best friends is an oncological pharmacist up in Salt Lake City at Huntsman Cancer Center. And I just think how cool would it be for me to collaborate with his brain for his knowledge of medication and pills, pharmacological therapy for different things, and have the benefits of that manifest in dysphagia. It's not something that I've, thought of so much so far. I mean, in graduate school, I've learned about timing, potential influence of timing with carbidopa, levodopa in patients with Parkinson's. And I don't want to say like anything that implies that's an exact science, but I've heard about that some, but it's not something that's like been on the forefront of my mind because I get so entrenched in just what we do all the time. The effortful swallow, the tucking your chin, turning your head, all those different types of things. But this is such a paradigm shift. And I just love seeing the potential that exists there and that there are data behind it to show promise. Where do you, I mean, this is such an open-ended question. Where do you see this going? What do you think is the potential? I mean, is it going to revolutionize everything? Is it probably not going to work, or like somewhere in between there? And I mean, I guess how specific maybe is better.
I think mostly it's always somewhere in between. I mean, I hope it's going to revolutionize everything. But in reality, I mean, it's probably, I mean, we won't cure dysphagia with it,
Sure.
but I think we really can improve quality of life, improve or reduce the complications for our patients. And I think this should be the goal. And the most important thing is really to work together. As you've mentioned, um, physicians and speech language pathologists, for example, the physicians usually focus on all these therapies. They know how high is the dosage, did we increase it, did we decrease it, and so on. And the speech language pathologists, they usually know how is swallowing. They've seen the follow-up investigations. They really know, did dysphagia improve or did it not improve? And we really have to bring this knowledge together in everyday clinical practice. I think this is the most important thing, because I've often seen it that the speech language pathologists know, oh, okay, dysphagia improved. And the physician knows, oh, okay, I've changed this and this medication. And no one really brings it together and says, okay, this medication might have improved dysphagia, and so on. So we really have to bring this knowledge together. I think this is the most important topic, as we've mentioned at the beginning, this interdisciplinary and multi-professional cooperation. And I think we can get better at doing this, and we have to get better at doing this. And if we get better here, we might maybe really revolutionize dysphagia treatment, not because we've collected much more research, which is also important, but just because we changed the way that we practice and cooperate together. Yeah.
Really bringing us away from being siloed and getting down to the differences in cause and effect, looking beyond correlation to other variables that can be contributory for causation. We have dependent variables, so the variables that are dependent on our intervention, and we have the independent variables, which are the things that we're changing. And so within a patient, you have a case study. You might have you have a physician involved, multiple physicians involved, and a neurologist, a hospitalist, and then you might have a physical therapist, a speech pathologist, occupational therapist. You have nursing involved, all of these different individuals. And so as a speech pathologist, if I come into this and I'm like, okay, I see reduced base of tongue retraction, there's molecular residue that's contributory to swallowing inefficiency. Maybe it increases their risk of airway compromise, laryngeal penetration or aspiration or whatever after the swallow because of the residue. Theoretically, maybe that's going to promote some negative outcome. They're going to be malnourished, or they might get pneumonia or something to that degree. So I'm looking at that and I'm like, okay, I'm going to do the effortful swallow. I'm going to have them do XYZ compensatory strategy, and I see them progressively get better. But maybe it has nothing to do with what I'm doing because I'm not looking at other data points. I'm not looking at the intervention from the physician. And so this bridges that silo. It really merges and brings things together that I think is eye-opening. It's almost like tunnel vision. What is it? With racehorses, sometimes they have the blinders on the side so they don't see anything else that's going on, and they just look straight ahead so they can get to the finish line. But with this, it's like it's taking those blinders off, and it's like, okay, what else is it? It's almost like enlightening to me to some degree. Like, oh, that's phenomenally cool. And I'm going through this. Is a new topic to me, so I'm trying to make sense of it and process a lot of it. And so I really appreciate this different angle to this. And as we wrap up, where is a good resource people can explore more about this? Are there a couple of articles that I can include within the link that people can go and look into? Maybe the meta-analysis that you mentioned earlier?
Yes, for sure. Exactly. I mean, there are good meta-analysis summarizing all these neurostimulation therapeutic approaches, and with regards to these applying dysphagia as therapeutic target of disease-specific therapies, there are also good articles. There is, for example, in Parkinson's disease, there is a so-called FIS levodopa test in which the responsiveness of dysphagia is analyzed with regards to applying dopaminergic medication. Then there is the FIS tensilone test with regards to myasthenia gravis. So applying acetylcholine esterase inhibition medication and then looking at does it improve dysphagia or not. There are specific protocols. So I can definitely send you some article. Yeah, and you can apply it to this podcast episode. Yeah.
Sounds good. Yeah, I'll throw some of those in the description. And
Okay.
and pretty soon you're going to be giving an hour lecture on this stuff at Rocky Mountain University's Hard to Swallow, A Catalyst for Change in Dysphagia Management virtual conference. And so hopefully people will see you there too. And definitely a plug for that. This is a little bit of a teaser, but I think this is totally stand alone. Even if people miss that, there are so many different ways that they can learn more about this, which is fantastic. Is there anything else that you'd like to leave the listeners with?
Well, I think we've wrapped it up quite well. I would just like to point out again this interdisciplinary cooperation. I think it's the most important thing. So wherever you're working, if you're a physician, get a good speech language pathologist and cooperate with him. If you're a speech language pathologist, go to your physician and say, you have to look at it as well. You have to cooperate with me as well. I think this is the most important topic. Yeah, thanks for inviting me, and I'm really looking forward to your conference. I think it's a great thing you're doing there. Happy to be a part of it. Thanks.
Yeah, thank you so much. And I truly appreciate the bridges that you're building and how you're really working to expand our minds at what is potentially causing or could cause these positive outcomes in our patients. So thank you so much, and have a wonderful rest of your day.
Thanks, you too, Tim.
That was the second episode of Season 2. Our guest, Dr. Bendix Labeit, will also be speaking later this week at the Hard to Swallow, A Catalyst for Change in Dysphagia Management Conference. It was an honor to have Dr. Labeit on the show to obtain his expertise as a neurology physician with a focus on dysphagia. As a reminder, our episode sponsor is Phagenesis, maker of Phagenix neurostimulation system for pharyngeal electrical stimulation, which is a fairly new concept to me, not to be confused with neuromuscular electrical stimulation. Check out the episode description for articles and resources, and please visit our sponsor at phagenesis.com to find out more. Thanks for hanging out, and we look forward to seeing you next time on Swallow the Gap.